Yes, my name is sorry. My name is Kagwa Anania, a cardiovascular technologist or cardiac physiologist, and I'm going to be presenting today about echocardiographic assessment of diastolic function. Diastolic function is of the heart. Echocardiography is using ultrasound to assess the heart function. So today, one of the functions of the heart we are going to be assessing or seeing how to assess them is going to be diastolic function. There is another function of the heart which is systolic function, but we are not seeing about that one today, only diastolic functioning. So we are starting with our introduction as usual. Diastolic function, if we are to define it, that is the ability of the heart to relax and fill with blood during the diastolic phase of the cardiac cycle. Remember the cardiac cycle, majorly there are two phases, which is systole and then diastole. In systole, the heart contracts to fill with, to eject blood, either to pulmonary circulation or systemic circulation. Now in diastole, the heart fills with blood, either from the right side, from the IVC and then SVC and then the coronary sinus, and then on the left side is from the pulmonary veins. That is diastole. So during the diastolic phase, so the heart fills. So that is diastolic functioning. So if that function is hampered, that is diastolic function is hampered, not working well, it is called diastolic dysfunction. That is the impairment of the ability of the heart to fill with blood during diastole. Echocardiographic assessment of diastolic functioning should be an integral part. That is, it should be assessed in almost all patients presenting with complaints of dyspnea or heart failure. Dyspnea can be there because the diastolic functioning of the heart is impaired, or systolic functioning of the heart is impaired, any of the two, and the patient will be in heart failure. So all patients presenting with complaints of shortness of breath, orthopnea, or PND, we have to assess by on echo diastolic functioning. So the 2009 American Society of Echocardiography and European Society of Cardiovascular Imaging guidelines for diastolic function assessment were comprehensive. That is, we assess using 2D image, Doppler parameters, that is to grade DD, and to estimate LV filling pressure. So we are going to use 2D images and then the Doppler echocardiography, either continuous, tissue Doppler, or pulse wave Doppler we shall use. So left ventricular diastolic function is a key player in determining left ventricular filling pressure and then stroke volume. If diastolic dysfunction is there, then less blood will be able to enter, for example, the LV, and then less blood will be ejected out at the time of systole. So if less blood is there, then stroke volume and the overall cardiac output will be decreased because of diastolic functioning, dysfunctioning. From now onwards, I will be using the acronym DD to denote diastolic dysfunction. So DD has been recognized in many cardiovascular diseases and is associated with worse patient outcomes or prognosis. That is including total mortality and frequent hospitalizations due to heart failure. Most of the time, diastolic functioning is not assessed. What they pay attention to, most of the sonographers, is systolic function. They assess it with ejection fraction. So once systolic function is assessed, whole motion abnormality is assessed, they stop there. So there are many mistakes or errors that are performed or they are done during echocardiographic assessment of the heart, including forgetting to assess diastolic dysfunction, diastolic functioning. So LV diastolic function is modulated by, now diastolic functioning of the heart or of the LV modulated by, that is RV LV interdependence. Those two, they interact depending on the phase of respiration, either inspiration or expiration. Left atrial function, that is the functions of the left atrium, is the pump function, the conduit function, those two. It's a pump, and then it's a conduit. And then the third one is the reservoir. Both atrias, their conduit function, that is, blood can just pass during diastole from pulmonary veins into LA, then to mitral valve into LV, that is conduit function. If blood just pass, like is stored, during, for example, during ventricular systole, blood is just collected in atria, that is reservoir function. And then, as the last part of ventricular diastole is the atrial kick, or the first phase of the cardiac cycle is the atrial kick. Whenever they contract, they are performing their third function, that is the pump function. So, diastolic feeding will be modulated by LV function. And then another one is pericardial influence on LV feeding. For example, in constrictive pericarditis, feeding is affected because the pericardium cannot allow the stretching of the heart to feed. LV systolic properties, if the systolic function is hampered, then diastolic dysfunction is there. Then diastolic synchrony, like dysynchrony, for example, in bundle branch blocks. And then coronary blood flow in CAD, that is coronary artery disease. And then tissue perfusion, like microvascular dysfunction, which is there. Diastolic dysfunction is going to be there in all these conditions. All these, we are going to affect diastolic functioning. So, in its broadness, diastolic function has two major components. Two major components are there. That is myocardial relaxation. It has to relax after contraction, it should relax. Then another one is stiffness. The chamber stiffness. How stiff is the myocardium? Are the walls of the ventricles? Can they expand whenever more blood is coming, or they are just stiff, they cannot expand? We are going to see one by one, and the first one is going to be myocardial relaxation. Myocardial relaxation, we are seeing the first component. On a cellular level, relaxation occurs when actin and myosin cross bridges are broken. That is, if you go back to physiology, you find the sliding filament theory, where the myosin head should attack its binding site on actin, and then ATP hydrolysis happens, a power stroke is initiated, and then after the power stroke, the myosin head should release its binding site and then attach on another site. But now that detachment requires ATP to break that bond. So ATP is required for relaxation. So it only occurs when that bond that was formed between the myosin head and its active site is broken. So a decline, if you break them, then contraction causes tension. Detachment of myosin head from its active site causes relaxation. Whenever it attaches, a power stroke initiated, pulled back. Actin is pulled. If it detaches, then it relaxes. It becomes flaccid. So a cellular tension, and it occurs in the diastolic phase of the cardiac cycle. Detachment occurs in the diastolic phase of the cardiac cycle at the start. The cardiac cycle, if you try to remember, or if I can remind you, this is the basics of cardiology. We have atrial kick, isovolumic contraction, rapid ejection, slow ejection, isovolumic relaxation, rapid feeding, diastasis, and then, yes, atrial kick. Again, we start again. They have 7 phases. So for this to occur, calcium must be taken up by the sarcoplasmic reticulum through the Sarca A2A pump, which is in turn regulated by PLB, that is phospholamban. Now, calcium is required. What is the function of calcium? Again, if I'm to remind you that calcium is required for cellular contraction, because before the myosin attaches to its active site on actin, tropomyosin is blocking that active site. That's why it cannot attach. Calcium is required, one, like for example in the cardiac muscle, for contraction, two, that is to increase the contraction, two, and then for action potential. Action potential and then contraction. Now we are talking about the contractile part. Calcium should be there. It has a site where it attaches on troponin. When it attaches troponin, troponin is linked to tropomyosin. Whenever troponin grasps calcium, it changes its shape. That shape, because it is that change in shape, because it is linked to tropomyosin, tropomyosin also change. Whenever it changes, the active site is opened. Now myosin can attach. It's like a magnet. It can attach. Now for it to cork and make a power stroke, it requires attachment is not enough. It should cork to pull. That is a power stroke. So after contraction, as long as calcium is still there in the cytoplasm, the active sites will be open and the contraction will continue. So in order to relax, calcium should be taken back. After the power stroke, calcium should be removed. And who removes that one? It is a sucker A2A pump. Regulated by phospholamban. We are going to say how phospholamban, or a regulatory protein, how it does. It affects sucker activity. In the heart failure patients, expression of sucker A2A is reduced at the gene level and the protein level, causing slow relaxation. If sucker is not there, and then calcium is going to stay there in the cytoplasm. So one part of the cells, some cells will relax because some calcium is taken back, but others will stay contracted because calcium is still there. So the effect is not a completely relaxed myocardium. It is a bit stiff and a bit flaccid. That one does not favor full relaxation, and thus it causes diastolic dysfunction. Phospholamban inhibits sucker A2A when unphosphorylated, whereas its phosphorylation by cyclic AMP protein kinase removes the EC inhibitory effect on sucker. That is its So if it's phosphorylated, sucker should be it should not be inhibited. That's in the first. It should not be inhibited. When do we need it to be inhibited? When we need a lot of calcium inside there in the cytoplasm, it should be inhibited. But if we don't need it there, it should not be inhibited. It should be left to act so fast to take away the calcium, and then the cytoplasmic reticulum, at the time of contraction, it should release it, a lot of calcium. Cyclic AMP protein kinase activation by beta-adrenergic agonists results in positive hallucinotropic effect, but energy is needed for these reactions to occur. Thus, ischemia leads to impaired relaxation. Even what we have said, if ischemia, what is ischemia? That is a mismatch. Ischemia is just a mismatch in oxygen supply and demand, and then failure to remove the waste products produced by cells, for example, lactic acid and then carbon dioxide. So that is ischemia. It occurs when blood supply is reduced, for example, in coronary artery disease, when a plaque is there and then it has blocked maybe around 80% of the vessel lumen. So, actin and myosin cross bridges, there is a photo there coming next, and this is what it shows. I'm not going to read, you read it yourself. But let me read. During systole, that is on the left side, calcium, that is yellow, is released from sarcoplasmic reticulum, and the troponin, that is violet, and binds to troponin. I already said these ones, I shouldn't repeat even. This causes tropomyosin, that is white, to shift its position. I'm not reading this one, but let me just keep it. To shift its position and exposes the myosin binding site on actin filament, allowing for a cross bridge formation. During diastole, that on the right side, active calcium uptake by sarcoplasmic reticulum results in another tropomyosin position shift that shields myosin binding sites on actin from myosin heads. This one has already said, and this is what they are saying. In cystine, we see calcium yellow binding to troponin. Then troponin, this is myosin, and actin is there. Troponin is linked to tropomyosin. Whenever calcium binds, configuration changes, active site white, exposed. In diastole, calcium is taken back, tropomyosin and troponin assume their resting position, binding site covered, and myosin head release. We need that one. Yes. So now, if we open, again, if you try to remember the microscopic structure of a muscle cell, we're going to see the contractile unit of a muscle fiber, that is a sarcomere. A sarcomere, it has troponin, it has tropomyosin, it has myosin, and then actin. Around the actin, there are tropomyosin and troponin. We are not seeing them here. But we have the central line, the M line. We have the Z line this side. And then they are saying the spring segment. We have been saying contraction, relaxation. But to relax is like something should, after contracting is squeezing and reducing the cavity size. Like in the LV, if it contracts, the cavity size reduces. That is not its resting position. Its resting position is when it is relaxed and full. So after contracting, it should release, then go back to its resting length. But to do that, there are other proteins that are integral parts of this sarcomere. And these are titin. These are structural proteins. Titin, they hold this actin and actin and myosin in position to allow the cross bridge to form. Otherwise, if they are not there, this arrangement can be distorted. This arrangement, if titin is not there, it's a big protein. If it's not there, this arrangement cannot happen. Contraction cannot occur, and deficiency of titin is one of the causes of muscular dystrophies. Deficiency of titin, it is one of the causes. So titin is a very important part of sarcomere. But it has two parts. It has two of them, isoforms. Isoforms, they are just two different, they are different forms of the same thing. It is the same, but it appears in two forms. So the two forms of titin, we have N2B and then N2BA. We have the stiffer one, stiff, and then the compliant one. So you choose what to have. Do you need a compliant heart or you need a stiff heart? What will determine it is the titin composition. If you have more of the compliant titin, your heart will be compliant and it will just go fill and it will not come back to contract. If you have the stiff part, it will not fill, it will not expand because it is stiff. So what do we need? We need both in appropriate ratios. In a normal heart, the stiff titin predominates. In patients with, for example, dilated cardiomyopathy, the ratio is changed, and the compliant one be the majority. So on these ones, who is the stiffer one? The stiffer one is N2B. The compliant one is N2BA. So this stiff one, because at contraction, when you see here, we have spring element. You see that word? The arrow facing down. spring element. So why is this spring? What do we expect in the siding filament theory? You see we have these black ones with dots inside, that is, they are thick, and then we have a bit gray lines straight from both ends of the Z lines coming towards the center. These, the black ones, they are myosin. These small ones, the gray ones, they are actin. So for contraction to occur, myosin heads will grasp one part of actin, and then when a power stroke is initiated, they will pull it. They pull it, this actin, towards the center. If you pull actin towards the center, it is supported by these red lines. So you will be making them taut. You will stretch them. If actin is pulled to the center, it will stretch these tighten components towards the Z line. They will stretch. That is not their resting position. Their resting position, they are like a spring. A spring rests when it is short. When you pull it and release it, will go back to its resting position. Same thing happens here. At contraction, tighten is stretched. So if you have the compliant part of tighten, there has no problem with stretching. So if you stretch it, it will be very easy to reach its elastic limit, and it will not come back. It will not be able to come back like that spring. Because it is compliant, it's okay. You can pull it. But the stiff one, you try to stretch it. Because it is stiff, it doesn't accept to be stretched. So the moment you release, it will come back like a spring. Whenever it comes back like a spring, then the sarcomere goes back to the resting position. That's what we want. And that spring, that coming back as a spring, it is very fast that it creates, if we check the entire LV cavity, it creates a suction, a rapid fall in pressure. A rapid fall in pressure at end systolic, for example, end systolic pressure was around 120 or 100. That suction, that springing, it can reduce that pressure to up to maybe 6 to around 6. There, I'm just giving an example. 6. So it can, from 100 to 6, it can do that in a very well compliant heart, a healthy heart, a young heart. It can do that. Or 6 to 0, it can do that. So that's how it is supposed to be. A suction has to be there to prepare for the next phase of the cardiac cycle. So that springing part, contraction, and then you release, you spring back to resting position. It has a time, and it's the name of the cardiac cycle, that is isovolumic relaxation. It occurs when the aortic valve is closed, but mitral valve is also still closed. If we talk of from the right side, the tricuspid valve is closed and the pulmonic valve is also closed. So no net blood flow, but the pressure within the ventricles fall rapidly. That is isovolumic relaxation. And we can measure its time. Its time can be measured, and the normal range is around, depending on where you're ready from, it can be around 70 to 90. If it's beyond 90, if it happens, the springing part, if it happens but happening so slow, we don't want that. So a time of more than 70, depending on the condition, or more than 90, depending on the condition of isovolumic relaxation time, it is not required. It's abnormal. It's an indicator of DD. A time which is less than 60 or less than 70, depending on the condition, it is happening so fast. If not, it is just cut short. It can be just cut short before it finishes. It is an indicator of diastolic dysfunction. So the normal range of isovolumic relaxation time is around 70 to 90. You have to find it somewhere there. But these are the proteins, titin, which are very important for that isovolumic relaxation, for that suction that is created during isovolumic relaxation, for that pressure gradient that is created between the atria and ventricles to allow for the next phase of the cardiac cycle, that is the rapid filling phase. So at ventricular level, myocardial relaxation is measured by the rate of left ventricular systolic pressure decay. I've said this one during the isovomic relaxation. I've said this one, period. A normal LV exhibits a faster pressure decline with low minimal pressures. That's why I've said maybe around 0 to 6 millimeters of mercury should be there. Relaxation among not relaxation. We are going to look at the relationship among the LV, left atrial pressure, LV pressure, and then Doppler velocities. So we've talked about myocardial relaxation. So how are you going to measure myocardial relaxation? That is one thing I've said already. Isovomic relaxation time. It will measure myocardial relaxation. Another measure of myocardial relaxation is going to be tissue Doppler. This one is going to be taken, isovomic relaxation time, I will show you at the end. It will be taken within or by recording the inflow of mitral inflow and then LVOT outflow. That is the LVOT flow. So we have to record both and then measure. Just after the cessation of ejection, the flat line that exhibits before you start the mitral E wave, that is isovomic relaxation, as we shall see. So we shall measure that time and then conclude whether it is normal relaxation or abnormal relaxation. But before, we have to see how is left atrial pressure, LV pressure, and Doppler velocities related. With normal diastolic function, this is what we expect. LA pressure and then LV pressure are normal with predominant early diastolic filling, short isovomic relaxation time, and deceleration time. Now, this is a new term, deceleration time. We shall see what is deceleration time and what does it measure. It measures LV stiffness. Diastolic deceleration time, it measures LV stiffness. Another measure of LV stiffness is E wave velocity. Mitral annulus, that is mitral annulus early diastolic velocity, that is E prime, exceeds A prime, that is A prime, that is taller than. Now, we are going to record to put a pulse wave Doppler at the opening of the mitral valve, and then we shall record blood flow velocities during diastole. I've told you the phase of the cardiac cycle. I said already, we have early or the rapid filling phase. Rapid filling phase should put at least 70% of blood into LV in rapid filling phase. Because of that suction, that pressure gradient created due to isovomic relaxation, it should be able to put at least 70%. The ventricle should fill up to 100%. But 70% should be in rapid filling phase, and then the 30% should be contributed by diastasis, if at all blood flow is still there, or by atrial kick. And normal one, since it is 70%, it should be having high velocity. In Doppler, we are recording velocities. So it should be E for rapid filling, and then A, two waves are recorded, E and A for atrial kick, and E for rapid filling. Always, since this one contributes 70 and the other one 30, rapid filling should be higher than A. That is normal functioning, normal diastolic function. E wave taller than A, but the velocities, the maximum velocities of E should not exceed 90, for example, 90 centimeters per second. It should not exceed. It shouldn't be so high. If it becomes so high, it is either abnormal or it's in young, fit people like athletes who have very, very compliant hearts. That's when it should happen. But in elderly people who are sick, it should not exceed 90. Most of the time they will say 50. If it's above 50, it's a problem. Here. So mitral E, from that, we can also record mitral annulus. If you remember anatomy, a valve surrounded by a fibrous ring, that is the annulus, where the leaflets are held, they are supported. The fibrous ring there. So the annulus, its movement, it can be recorded using the tissue Doppler, TDI. Pulse tissue Doppler. So as inflow for velocities, also the E, we have two annular. We have the septal towards the interventricular septum, and then the lateral towards the lateral side. So you can record both, and they are represented as E prime. This E you are seeing in the bracket, prime, and it also has its A, like the inflow, and it's A prime. But this time around we are using small letters. For the inflow we are using capital letters. Onset of E precedes onset of A. After filling, E wave, filling should come first because the pressure is already low. The ventricle should not just start expanding. So it measures the myocardial movement because of expansion. But before, E should be there. Blood should first enter LV before the ventricle starts expanding. It should just expand when the space created already is filled, and now it needs to accommodate more blood. That's when it should move. So E, the inflow, should occur before. No, because of relaxation, small E should occur before E, A, the inflow. Relaxation, it moves, it expands, springs, comes back to its resting position. That is E1, E prime. And then next, blood flows. But if relaxation is hampered, then blood will flow fast, and then it tries to expand. Again, I'm repeating, my mistake, I'm sorry. E prime, because of isovomic relaxation, should happen fast. And then E, blood flow, next. With impaired LV functioning, with impaired LV relaxation, but normal air pressure, early diastolic transmitral pressure gradient is reduced, leading to reduced E wave velocity. Now this is what happens. If we need to understand diastolic functioning, we have to really understand hemodynamics. So what do we have? Hemodynamics. Blood should just move straight. We should keep LA pressure as low as possible, and the LV pressure and diastolic pressures as low as possible. And we should create enough pressure gradient to drive blood flow. Blood flows following a pressure gradient. If there is no pressure gradient, no blood flow is going to be there, and stasis of blood will be there. We don't want that. So if isovomic relaxation is impaired, the pressure gradient, the one we said from 100 to 0, is not going to be there. Maybe it just relaxes up to the middle. Maybe it can, instead of coming from 100 to 0, it comes from 100 to 50. So the pressure gradient is only 50. What will happen? The more the pressure gradient, the more blood that can flow. The lesser the pressure gradient, the less blood that can flow. 100, for example, in left atrium, I'm just giving as an example, it's not true. That is way too high for the left atrium. 100 millimeters of mercury, we need blood to flow from LA into LV in early diastolic filling or rapid filling phase. At the end of systole, the LA pressure is around 100, for example, and then at the end of isovomic relaxation time, the LV pressure is 0. What is the pressure gradient? It will be 100 minus 0. That is 100. That 100 should drive 70% of blood into LV. If isovolumic relaxation is not finished, or it happens but incompletely, because this person is having a high percentage of compliant tightening. It just happens and stops in the middle. And at the end of isovolumic relaxation, the LV pressures, they are around 70. Instead of 0, it is 70. So what it would be the pressure gradient. The LV pressures have not changed. They are still normal at 100, but the LV pressures at the end of isovolumic relaxation, they are 70. So what is the pressure gradient? It is 100 minus 70, which is 30. Normal one should be 100, now it is 30. The lesser the pressure gradient, the lesser the blood that will flow. If little blood flows, little velocity, E wave velocity will be recorded. And if instead it should be 70, now it is putting 30%. Meaning the atrium, the left atria has to work to feed the LV by the 70% of the LV. So its contraction should be so strong to send 70% of blood into LV, because at a rapid ejection, rapid feeding, it only put 30%. So 70%, the heart should not contract, the LV should not contract when it's not full. The atrium, the left atrium should contract to generate a pressure that will push 70% of the remaining blood into LV. I should do that. So that one will reverse the thing. Instead of a taller E, it will be a shorter E and a tall A wave. A shorter E wave and a tall A wave. When the diastolic dysfunction has started, it has kicked in. That will be grade 1 diastolic dysfunction, if we are to grade it. When E wave is shorter than A wave. Yes, this is what we are having here. We have in green normal LV diastolic function, and then normal left atrial pressure, and then in red high left atrial pressure. But these two, normal LV pressure and high left atrial pressure, they are housed in one component, that is impaired relaxation. So one is showing it should be LA pressures and then LV and diastolic pressures, LV and diastolic pressures, and then LA pressures. That one in green. But so far what I've said about E and A wave. That's what I've said. And then we talked about isovolumic relaxation time, and then a little about deceleration time. Now we are going to finish deceleration time from here. The first wave is E, that is the rapid feeding phase. But before E, in blue, there is a flat line there, which should be a period after the closure of the aortic valve and the opening, between the closure of the aortic valve and opening of the mitral valve. Whenever mitral valve opens, E wave starts. So that flat, or that baseline, it is isovolumic relaxation, and this duration can be measured on echo, and we find out how much. And then from there, from rapid feeding, because the pressure gradient, whenever rapid feeding is there, blood is moving from LA into LV, so the pressure gradient keeps on decreasing until when it is almost equal. When it is almost equal, blood flows following a pressure gradient always. If the pressure gradient ceases to exist, blood will stop, will stand still, it will not be flowing. And that one is called the period of diastasis, waiting for the impulse to come from SA node, depolarize the atria, and then the atria to contract. So when the atria contract, then A wave, another 30% of blood comes into the LV by force now. And then after that, the mitral valve closes. So that is, the first one is the normal diastolic function. The next one is just what I explained a few seconds back or a few minutes back. When E wave becomes shorter than A wave. And now they have drawn some dotted lines in white in E, showing from the tip towards the end up to the end of E wave. And that one will be called the deceleration time. How fast does the E wave velocity decompose after reaching its peak? If it decomposes so fast, we don't want that. If it decomposes so slow, again, we don't want that. So what do we want? Meaning there is a normal range of deceleration time. We are measuring the time. There are black arrows here, small ones. One, big arrows for isobaric relaxation time, and then small arrows, black, pointing up, therefore deceleration time. It shouldn't be so fast. It shouldn't be so slow. So what is the normal range? The normal range of deceleration time, E wave deceleration time, is around 160 to around 240, depending on where you get the information from, to around 240, or somewhere they said 260. That is milliseconds. It should be there, 160 to 240 milliseconds. If it's above 240, that is abnormal. It implies grade 1 diastolic dysfunction. If it is less than 160, that is abnormal. It implies grade 3 diastolic dysfunction. So I've talked of grade 1 and grade 3. What is grade 2? Grade 2 is when it is pseudonormalization. Pseudonormalization, meaning E wave becomes tall again and A becomes short. Why? Why does it happen like that? Because the pressures, the heart is always intelligent. It tries to compensate for whatever happens. For whatever pathology, the heart will try to compensate. So the heart, after realizing that the ventricles are no longer compliant, the pressures will increase. But now, because 70% in the normal one, 70% was by E wave, 30% was A wave, the DD1 has come when 70% is for LA and 30% for A wave, and then 70% for A wave, and then 30% for E wave. The LA cannot withstand that pressure. Meaning the normal 100, it will be, the heart will think this is not enough. We need to build a higher pressure to increase the pressure gradient from 30 to around at least 70. And it will do that. The pressure in LA will increase to create a higher pressure gradient from 30, which initially it was LV 70, LA 100. So it will increase its pressures from 100, if 100 was the normal one, to around 150. It can do that. These figures are so high, it is not true for LA, it is not true for LV. I'm just using them as examples. So from 100 to 150, and the LV pressures at the end of isobaric relaxation, it has not changed. It is still 70. So we shall get 150 minus 70, 80. 150 minus 70, yes, 80 millimeters of mercury. Pressure gradient is generated almost towards the normal, which was 100. So what will happen? That pressure gradient will be high enough to make sure that at least instead of 70, at least 60% of blood enters LV by rapid filling, and then 40 enters LV by atrial kick. But the decay of E wave velocity, it will be so slow. It is not fast. It will decay slowly. But at least E wave will be taller than A wave, and that was the feature of normal diastolic function. It's not true that it has come back to normal. It is just because LA pressure has increased. LA has upgraded its game from 100 to 150 when the LV is still sleeping at 70. Yes. That is what happens. Pressure gradients, how they are built up. And then below we have, see, if you read on the vertical axis, first one we have tissue Doppler velocities, mitral inflow velocities in centimeters per second, and then LAV and then LA pressures in millimeters of mercury. I'm not focusing on these graphs because there are other topics where these graphs are explained very well. So below, I told you E and A. E, capital E, and then below it is E prime, small e prime. And then below capital A, there is small a prime. These ones are positive, the capitals are positive, the flow is positive, and then the lowercase letters, they are negative. Why? This is because of transducer positioning. When you are taking the view, most of the time it is measured in apical four chamber, where the transducer is put on the apex. So if the transducer is put on the apex, so in the normal flow, blood will flow from LA into LV, meaning the LV, the blood will be coming from the base to the apex towards the transducer. That is a positive flow direction. Now for annulus, I told you these are mitral annulus. It instead goes upwards. When it's expanding, it goes upwards. Contraction, the atria are pulled to the base, the base of the heart, that is the atria, they are pulled to the apex. If it relaxes, the recoil, they go up. That movement going up is away from the transducer. It is negative. I think that one is finished. I'm not going to talk about this fluid challenge. When area pressures are high, when area pressures are high, I've already talked about this one. Area pressures are high, E wave becoming taller than A, but with a very long, prolonged deceleration time. Whew. Now, measures of myocardial relaxation. We have measures of myocardial relaxation. We have relaxation. Measures of myocardial relaxation or stiffness. We have relaxation, and on the other side, stiffness. Relaxation is measured by IVRT, I already said that, and then septal E, annulus, annular movement, mitral annular movements, either septal or lateral. Then stiffness, A wave transit time, and then mitral E wave velocity and its deceleration time. I've already said this one, and you have seen what is deceleration time and then what is E wave velocity. A Doppler will record velocity. I hope you know that. Causes of diastolic dysfunction. One, when you're doing an echo exam and you find any of these, just know diastolic dysfunction is there, and what is remaining is to grade it. If you find hypertrophy, it doesn't matter whether it is hypertensive heart disease, hypertrophic cardiomyopathy, restrictive cardiomyopathy, or stenosis, aortic stenosis, or pulmonic stenosis, PS, diastolic dysfunction is there. Just grade it. Ischemia in coronary artery disease, if a patient of a known case of ischemic heart disease, diastolic dysfunction is there. Just grade it. Fibrosis, diastolic dysfunction is there, like sarcoidosis, where like restrictive cardiomyopathy, or ischemic heart disease, ischemic cardiomyopathy. Diastolic dysfunction is there, just grade it. Constriction, that is constrictive pericarditis, what? Diastolic dysfunction is there, just grade it. Calcium overload situations. Like calcium can be overloaded in conditions like digoxin use. Digoxin is a drug used in heart failure. If it becomes toxic, it can cause calcium overload. And then the other thing is ischemia. Ischemia. So you have to check diastolic dysfunction is there, because this is what we said, we described at the start. A calcium should be taken back. If it is left inside the cytosol, the cell will never relax. It will stay in a contracted state. So if calcium overload is there, that is calcium overload inside the cell, it is going to do what? It will not be taken up by cell. Calcium overload can be failure of the Saka ATPase pump that should take it back into sarcoplasmic reticulum. So if it remains there in cytosol, no relaxation. Then ATP depletion. I've been telling you that these processes are energy consuming. So if ATP is not there, diastolic dysfunction is there. So all causes of ischemia, diastolic dysfunction is there. Just grade it. Factors affecting diastole, we've already said these ones. That heart rate, atrial function, we said these ones, I'm not repeating. Hemodynamic determinants of echo variables. Again, I've already said these ones. Mitral E-A ratio, I've explained. E-wave velocity is dependent on LA-LV pressure. This one I've even given examples. E-wave velocity is dependent on LA-LV pressure gradient during late diastole, yes, and therefore LV stiffness. Now, E-wave, in conditions where the atria cannot contract, for example, in EAF, atrial fibrillation, the contractile function of the atrium is lost. So will the A-wave be there? No. Because contraction increases the LA pressure, and that's when it can exceed the LV pressure to force the 30% of blood into LV. If atrial fibrillation is there, it cannot. Or if LA is enlarged. Sorry. It cannot. Increased ratio usually predicts, that is EA ratio. We take the EA ratio. This is what he's saying. Mitral EA ratio. Increased ratio usually predicts elevated or increased LV filling pressures. The normal ratio of EA should be more or equal to 0.8, but not more than 2 in elderly sick patients. But in normal, physically healthy patients or subjects, it loses meaning, because we can find, like in athletes, EA ratio of around 2.5 or even 3 in athletes who are doing aerobic exercises. So in healthy individuals, it is useless. But in sick elderly patients, it is very important in deciding and grading diastolic dysfunction. 2. Deceleration time. I've already said this one. E-wave deceleration time influenced by rate of decline in LA LV pressure gradient after mitral valve opening, and therefore LV stiffness. This is what we say. Shouldn't be stiff. It shouldn't be stiff. It should be stiff, but it should expand. That's why I said number one should have some stiff tightening and some compliant tightening. When LV relaxation is slow, LV relaxation also affects. When LV relaxation is slow, LV relaxation also affects DT. If it relaxes so slowly, then DT is going to be cut short. Next, isovomic relaxation time. These are the things we are going to take in order to diagnose diastolic dysfunction These are parameters we shall measure to diagnose diastolic dysfunction and to grade it, because it is graded based on American Society of Echocardiography, grade 1, grade 2, grade 0 is normal, grade 1, grade 2, and grade 3. So submit relaxation time, I've already said this one, I explained it, I'm not repeating it. Read it yourself. Now, what I didn't talk about is pulmonary vein systolic to diastolic velocity ratio, SD. What are SD? You can record the pulmonary vein flow in apical flow chamber. You put the Doppler gauge at the entrance of the pulmonary vein into LA. When you put it there, I record the pulmonary vein flow during the entire cardiac cycle. We have 2 positive waves and 1 negative waves. The positive wave is the systolic wave, S wave, the first one. Second one, positive